Thank you for joining me today. Today I want to talk about a patient that I met outpatient clinic. She was a 30 years old female, and she presented to the clinic seeking an evaluation for several months of persistent internal change. She arrived on time, and she was neatly dressed and polite. But there is a noticeable sense of effort in her demeanor. She sits upright and attentive, yet appears fatigued in a way that suggests a sustained strain rather than acute stress. So she was not acutely stressed, but there was something tells you she is fatigued, weak, low energy. You can sense it that. She described the ongoing difficulty with emotional engagement and daily function. So she'd been having a hard time with engagement and doing her daily task, while she continues to meet work and personal responsibility. She reported that ordinary task now requires deliberate effort. Activities that were previously automatic feel slow and burdensome. Rest no longer restores her energy, and medical clarity has declined. Mental clarity has declined. So she has a low energy, she has low mental clarity. Her account emphasizes fatigue, reduced motivation, diminished concentration, and refreshing sleep. So she will be sleeping, but she's not getting refreshed or energy or out peak that when you wake up you feel rested. With relatively less emphasis on emotional reactivity or anxiety. She acknowledged discouragement related to these changes, but denies suicidal intent or plan. The dominant theme throughout the visit is a sense of mental and physical inner rather than sad alone. So her medical and psychiatric background, her medical history is unremarkable. So she don't have any medical history with no endocrine or neurological or chronic medical condition. Recent lab work is with the normal limit. She has no previous psychiatric medication trials, no history of mania or hypomania or psychosis or seizure or eating disorder. So she don't have any of these. She previously engaged in a brief counseling during her college, but did not require ongoing care. So she had a counseling, but no treatment after that. She takes only a oral contraception and reports no substance use and has a stable social environment. Family history is notable for depression in the first degree relative. So her first relative has the depression treated successfully with medication. One of her first family member had a depression, but they take medication and they have been successful. Clinical impression. Based on the symptoms, duration, functional impairment, and clinical history, the patient meets the criteria for major depression disorder. Single episode, moderate to severe. Presentation characteristics include permanent fatigue, inertia, reduced initiative, and follow thought. Cognitive is inefficiency, minimum anxiety or emotional volatility. This symptom is constant a point is toward dysregulation in a brain system relate to drive, energy, and reward rather than primary emotional dysregulation. Treatment and discussion and rationale. The initial treatment discussion focuses on explanation of the depression. So you educate the patient about the depression and the treatment plan as the condition of impaired brain coordination rather than lack of effort or emotion. The provider emphasizes that the pharmacology treatment does not alter a personality or impose emotional state, but instead helps the brain system to reestablish function timely and efficiently. Medication options are discussed with the patient in terms of what symptoms they best support rather than medication class or chemical targets. Some medications are prescribed as a primary reducing emotional burden rather than and relatively, while others are described as a supportive energy and focus on cognitive momentum. Some of the medications improve the energy, some of them they improve the cognitive momentum. Given this patient predominantly symptoms, low energy, diminished motivation, so she has low energy, diminished motivation, slow cognitive, and minimum anxiety. Treatment is ordinary. And treatment is oriented toward restoring a mental activation rather than further emotional dependent. Choice of medication include Bupropion. Bupropion is selected as an initial pharmacology intervention. This choice is guided by the patient marked fatigue, because she says she is fatigued, and motivational improvement, lack of significant anxiety symptoms, desire to avoid emotional burden, or sexual side effects. Absence of the contraindication such as seizure disorder or eating disorder. Those are the reasons you choose Bupropion. The medication is framed as one that supports mental clarity. So this medication supports mental clarity, initiative, it will give you motivation, and engagement, with the goal of restoring a momentum rather than stimulating or sedating. Treatment plan include Bupropion of 150 mg daily. Adjunctive interventions include behavior activation strategy, sleep-wake regulation, and referral for psychotherapy. Follow-up schedule is you will schedule 2 to 4 weeks, within 2 to 4 weeks, to assess the tolerance and early response. So the follow-up, when you prescribe the medication, you want to schedule that follow-up appointment and see if the patient is tolerating the symptoms of the Bupropion and if they are responding to. Expectations are set that improvement is gradual, that dose adjustment may be required based on the response. So you will adjust the dose based on the response. Patient education and safety monitoring. Patient is educated about the gradual onset of the therapeutic benefit. This medication works gradually. It's not quick fix, but it's gradual. Possible early effects such as mild activation or restlessness. So it will help motivation and calm improves adhesiveness, and avoid abrupt changes. Ongoing communication regarding side effects or concern. So you will educate the patient if they have side effect, if they have a concern, they should come to the clinic to talk about it instead of stopping the medication or quitting it. Safety monitors include some of the side effects: insomnia, irritability. Those are some of the medication side effects and major depression disorder symptoms: insomnia, irritability, anxiety in the early treatment. Because this medication, Bupropion, works gradually. It don't work quickly. It will take time all the symptoms of the depression subside. The lower dose depends. But the dose depending is seizure risk and a strategy to mitigate. This patient may increase the risk of a seizure. So what you're doing is you prescribe this medication for the patient who don't have a history of seizure. Clear instruction, follow-up, and symptom reporting. You want to educate the patient to report their symptoms, to follow up any changes or abnormal changes if they have. You want to build that relationship with the patient so they can communicate for their treatment. And the treatment outcome that you will want to see include approximately will be 4 weeks. Patient will feel relief or motivated or do the things they supposed to be doing, daily task normally, not effort, not tiring, not burden, but they feel okay to do it, okay to function. And the patient reports notable improvement in the morning energy, cognitive efficiency. They can do the task more appropriately. Their mental resistance is initiating activity is more. They can concentrate at work and has improved without sense of overwhelming feeling. At the 8 to 10 weeks, they gain more motivation and sustainable effort. Mood is bright, energy is more consistent across the day. They can sleep at night. No significant side effects are reported. Those are the outcomes you want to see. The functional recovery is evident in both occupational and personal. So patient is doing better for occupational and social, and when you have that appointment with them, they feel better, they have a more energy, they have more positive outlook up in life. So that's the outcome you want to see. Clinical reflection. This case illustrates or shows the importance of a matching antidepressant medication selection to the symptoms of the patient rather than the diagnosis alone. You want to listen to the patient and consider all their symptoms, history, medical comorbidity, and then you choose the right medication for that person. Unique. Everybody's unique, so that person, which one is good for these symptoms, because not every person experiences same symptoms. This person may have more symptoms this way. Let's say some people have more low energy, some people have more insomnia. So you will match the medication that is better for that particular patient. Patient did not require additional emotional support. She requires restorative of the drive and cognitive reaction. She wants to be motivated and focus on her job. Bupropion has effective because it addresses core dysfunction for fatigue, alertness, reduced engagement. So it improves energy, improves cognition, improves motivation without suppression of an emotional response. Medication did not change the patient personality or emotional. It reduces the neurological resistance that had made a daily function disproportional effort. So that is why you choose this medication. Thank you for joining me today. Please subscribe if you gain any benefit from the story, and I am planning to do more story like this. And join me my next video. Thank you.